Good morning, everyone. Today we will talk about transition at birth. So, transition after birth is a very complicated process. So many changes happens at birth. If these changes happen smoothly, then newborn baby stabilizes quickly. If some problems happen during transition, then so many disorders can happen in newborn babies like TTNB, PPHN, shock, respiratory distress. So, what are these physiological changes and what are the implications of this that we will discuss? So, we'll talk about fetal circulation. How is different from neonatal circulation? Fetal hypertension, fetal pulmonary hypertension, physiological hypertension is there in fetal, and fetal to neonatal transition. What are the changes that happens? About placental hemodynamics and placental transfusion. In this, we'll discuss what is the logic behind the delayed cord clamping and transition in term newborns or transition circulation in preterm newborns. So first, coming to fetal circulation. So fetal circulation, we can see here in fetus, site of gas exchange is placenta. So a gas exchange happens at placenta, not at lungs. So here oxygenated blood will come to the umbilical vein. Here gas exchange happens and oxygenated blood come to umbilical vein. This red one is oxygenated blood. Relatively oxygenated blood is going in umbilical vein. From umbilical vein to this will bypass to hepatic circulation through the ductus venosus. So ductus venosus is the shunt that bypasses the hepatic circulation, and this oxygenated blood will go to the inferior vena cava. From inferior vena cava, blood is going to RA, right atrium. And from right atrium, most of the blood will go to the left atrium through the foramen ovale. Because here right side pressure are high because of pulmonary hypertension. Right atrial pressure is high. And because of this direction also is towards the left. So most of the blood, oxygenated blood is entering from right atrium to left atrium. This oxygenated blood is going in left atrium to left ventricle, and from left ventricle this blood will enter to aorta, and from aorta this will supply to the brain. So cerebral circulation is getting relatively oxygenated blood in fetal life, and this coronary circulation also is getting oxygenated blood. This after this oxygenated blood, this SVC, superior vena cava, will drain the deoxygenated blood from hepatic circulation upper body, and this deoxygenated blood will enter in RA. And this deoxygenated blood, most of the blood will go to RA to RV. RA to RV. So deoxygenated blood is going to the RV. And from RV to this blood will enter in pulmonary artery. And from pulmonary artery, because pulmonary pressures are very high, lungs are collapsed, lungs are filled with the fluid, lungs are not expanded. So this blood will not go to the lungs. From pulmonary artery to this blood, only 10% blood is entering to the lungs. 90% blood will go from pulmonary artery to descending aorta through the PDA. So this was the pulmonary artery, and blood is entering descending aorta through the patent ductus arteriosus. So this deoxygenated blood is going to the descending aorta and then will go to the lower body. So in fetal circulation, brain and upper body is getting relatively oxygenated blood, but lower body is getting relatively deoxygenated blood through the PDA. So this differential circulation is there in fetal life. So three shunts are there: ductus venosus bypassing the hepatic circulation, pulmonary this foramen ovale, this bypassing from right atrium to left atrium, then PDA PDA direction in fetal life is right to left because right side pressure, pulmonary pressures are high. So shunt direction is right to left. So deoxygenated blood is going here. After from lower body, that venous blood is drained from the umbilical arteries. This umbilical artery through deoxygenated blood will go to the placental circulation, and here this will be oxygenated, and then again through umbilical vein this will cycle will start. From umbilical artery the deoxygenated blood is coming, here oxygenating, then through umbilical vein again oxygenated blood will go. So this is the fetal circulation. Here ductus venosus, three shunts are there, foramen, ovale, and ductus arteriosus. So fetal circulation is a parallel circulation where some intracardiac and extracardiac shunting is there. Their mixing is happening. And both ventricles are working together to provide systemic circulation. So both here, because pulmonary circulation is not there, both the ventricles are supplying to the systemic circulation. Right ventricle also is supplying to systemic circulation through PDA. Left ventricle also is supplying to the systemic circulation. So majority of right ventricular outflow bypasses the unaerated lungs and provide blood flow to the lower body through the ductus arteriosus. To prioritize oxygen delivery to coronary artery, cerebral circulation, left ventricle receives oxygen. So left ventricle oxygen, relatively oxygenated blood that will supply to the coronary arteries and cerebral circulation. So here, right to left shunt are there, foramen, ovale, and patent ductus. So in fetal life, shunt direction is right to left because the right pressures are high. Okay, and relatively hypoxic environment. Fetal life is in relatively hypoxemic environment. PaO2 and PaO2 is very low in fetal life. You can see everywhere PaO2 is around 25, 30, or 40 up to this only. Okay, and pulmonary circulation is high resistance, low flow circulation because lungs are collapsed, filled with fluid. Now, coming to transitional circulation. So, after birth, what happens? So, in fetal life, site of gas exchange in placenta. In newborn life, it's lung because lungs after birth, lungs are expanded and alveoli are now expanded, and gas exchange happens in lungs. In fetal life, this circuit is parallel. After birth is series. Pulmonary circulation in fetal life is vasoconstricted. Lungs are collapsed, and pulmonary circulation also is vasoconstricted. But after birth, because of oxygen and because of expansion of lungs, the pulmonary circulation are dilated. Vasodilation happened after birth. Fetal myocardium also in fetal life is less contractile or less compliance. Compliance is very less in fetal life. Myocardium, left ventricle also less compliant and less contractile. After birth, compliance improves, contractility improves. Dominant ventricle in fetal life, it is right ventricle because pulmonary pressures are high. Because of that, right ventricle is muscle mass is more, is dominant ventricle. After birth, because of systemic increase in systemic vascular resistance, left ventricle muscle mass increases, and dominant ventricle after birth is left ventricle. Some structure changes also happen. Umbilical vein will become ligamentum teres. Umbilical artery will become medial umbilical ligament. Ductus venosus will become ligamentum venosum. Ductus arteriosus will become ligamentum arteriosum, and foramen ovale will close and become fossa ovalis. So these changes happen after birth. So at birth, neonatal transition, what is happening? We can see here. So lung liquid is replaced with air. So during birth, air fluid is filled, but during birth, epithelial sodium channels are activated that will absorb the fluid of the lungs. And because of oxygenation also increasing, oxygen is a pulmonary vasodilator. So this pulmonary vascular circulation also is vasodilation will happen during in pulmonary vasculature. So lungs are expanded at birth. Pulmonary vascular is vasodilation is happening because of oxygenation. So because of this, pulmonary vascular resistance will decrease. There will be fall in pulmonary vascular resistance, PVR. Decrease pulmonary vascular resistance. Because of this decreased pulmonary vascular resistance, right ventricle afterload also will decrease because of now pulmonary pressures have reduced. So right ventricle afterload also will be reduced. Because PVR has reduced, so pulmonary blood flow also will reduce. Now from right ventricle, blood will flow to the pulmonary circulation because now PVR has reduced. So pulmonary blood flow will reduce. From pulmonary blood flow has increased now, so that's pulmonary venous return also will increase to the LA. Pulmonary blood flow is coming again to the left ventricle. Because of this pulmonary blood flow is coming to the left atrium, the left atrial pressure will increase and the foramen ovale will be closed. Because now, because of pulmonary flow is increasing, this pulmonary flow will come through the pulmonary veins to the left atrium and left atrial pressure will increase. That will close the PFO, pulmonary patent foramen ovale. So this shunt will be closed. So after birth, what is happening? That low resistant placental circulation is now no more. Sudden increase in systemic vascular resistance after cord clamping. There is sudden increase in afterload of systemic blood flow, and this decrease umbilical venous blood flow, constriction of umbilical arteries, constriction of the umbilical, this ductus venosus and umbilical vein also is constricted after birth. Ductus venosus also will be closed after birth. Foramen ovale also is closed after birth, and ductus arteriosus also will be closed after birth after exposure to the oxygenation. So because of increased oxygenation in the blood, that will cause constriction of the ductus arteriosus and closure of ductus arteriosus. So these three, all the three shunts are closed. If ductus arteriosus is there, that shunt direction will become left to right because now systemic vascular resistance has increased, left side pressures have increased. Shunt direction will change from right to left, now left to right. So these changes happen at birth during transition. Myocardial compliance also will increase after birth. So here fetal circulation was there. Now there is no fetal circulation. Cord clamping has done. Placent circulation is now lost. Now baby started breathing. Because of that, there is decrease in PVR, 5 to 10 fold decrease in PVR. Because of that increase pulmonary blood flow and increase in left atrial pressure. And because of that, functional closure of foramen ovale. Functional closure of the foramen ovale will happen. And because here there is rise in PO2 and fall in the prostaglandin. Now, because placenta is not there, so placental prostaglandin production is not there. Prostaglandin was keeping duct open. Now, prostaglandin is not there, and there is rise in oxygen also. That these two will close the ductus arteriosus. This cause constriction of the ductus arteriosus, and ductus arteriosus will be closed. Foramen ovale is closed, and there is reversal in shunting because PVR has reduced. PVR has reduced, but SVR has increased. Systemic vascular resistance increased. So there is reversal of ductus arteriosus shunt from now left to right. So these are the changes fetal to neonatal circulation at birth. Now coming to placental hemodynamics and transfusion. So placenta, as we have discussed, is the principal site of gas exchange and metabolic exchange for the fetus. A fetoplacental unit hold around 110 ml per kg of the blood, and blood flows from placenta to the baby even after 5 to 7 minutes after birth also because of the contractions. So placental transfusion is, what is the placental transfusion? Net transfer of blood to the baby after birth before cord clamping. So in this, baby can get 28 ml per kg of the blood, extra blood from the placenta. So what is the logic behind delayed cord clamping? Why we are doing delayed cord clamping? Is it because only that baby is getting some extra blood, some extra hemoglobin. Is it that or something else is there? So in this we'll see. So how this after cord clamping, here we have done immediate cord clamping. Is routine practice is there. If we do immediate cord clamping, then what will happen? Increase in systemic vascular resistance. After cord clamping, there is increase in systemic vascular resistance. And there is loss of the umbilical venous return also, because here cord clamping is done. So because of this umbilical artery is closed now, because of that increased vascular resistance, systemic vascular resistance. Now umbilical vein also is closed. So there is no venous return to the RV, because now umbilical vein also is closed. So loss of umbilical venous return also. So venous return is lost and afterload has increased. So what will happen? There is left ventricle increase afterload and there is decrease preload. Because of these two things, there is decrease in the preload, loss of the preload, and there is increase afterload. Both things are happening together, increase in afterload of left ventricular and decrease of the preload of left ventricle. Because of that, there will be decrease in the left ventricular cardiac output and there will be decreased cerebral blood flow. Because of these two things, there will be decrease in cardiac output. Because of that, baby can go in shock, hypotension, hypoperfusion. Cerebral perfusion will be decreased. Because of that will cause cerebral hypoperfusion. Then hypoperfusion, reperfusion injury will happen after that when blood flow will increase. Then hypoperfusion, reperfusion will injury will happen and death will cause IVH in preterm babies. Second, baby is going in shock, hemodynamic instability. Because of that, because afterload is increased and preload has decreased, so cardiac output has decreased. So this is happening if we are doing immediate cord clamping. So because of immediate cord clamping, reduces the venous return to the heart and instantly increase the systemic vascular resistance. So arterial pressure rapidly increased by 30%, cardiac output decreased by 30%, cardiac output remains low until the ventilation commences. So cardiac output will be decreased until the ventilation commences and pulmonary blood flow increases. Okay, so this is happening in immediate cord clamping. If we are delaying the cord clamping, if we are doing delayed cord clamping, then what is happening? Here we are not clamping the cord. So venous return is maintained. Umbilical venous return is maintained. Okay. So umbilical venous return is maintained and pulmonary venous return. So umbilical venous return is maintained. That will supply to left ventricular preload because now there is no clamping. So umbilical venous blood will go to the RV, RA, and then RV. Okay, and some blood will go to the LA also, to the LA to LV. So this will supply to the preload, umbilical venous return. Until there is increased pulmonary blood flow, this will supply the preload and there will be stable left ventricular output and cerebral blood flow. Because now there is no decrease in preload. So that will supply the preload and cardiac output will be maintained and cerebral blood flow also will be maintained. So here is happening after that, after some time what happen? Lung aeration will start. There will be clearance of the lung fluid, increase pulmonary blood flow, decrease PVR, increase blood flow. So after that, increase blood flow, that increased blood flow will supply to the left atrium to the left ventricular. So after the lung aeration happens, increase in blood flow, the venous return and ventricular preload are maintained by the umbilical venous return. Before the pulmonary blood flow is increased, the venous return is maintained through the umbilical venous return, preload is maintained. As soon as pulmonary blood flow increases, the preload will be maintained by the pulmonary blood flow. So this is happening if we are doing delayed cord clamping. By delaying cord clamping, we are allowing the venous return to be maintained and supplied to the preload. There is no increase in afterload, there is no decrease in preload. So cardiac output is maintained. The baby will not go in shock. Hemodynamic stability will be maintained. There will no cerebral hyperperfusion, so there will be reduced risk of IVH will be there. So this is the logic behind delayed cord clamping. What is the physiological rationale behind that we have discussed here. Now, what are the benefits? NRP also recommends delaying cord clamping at least 1 minute. Some people are doing for 3 minutes also. So that will reduce the risk of mortality, reduce the risk of low Apgar score at 1 minute, decrease need of the blood transfusion in infant, improve neurodevelopmental outcome, but there is an increased risk of polycythemia and hyperbilirubinemia that can be managed. So baby will get 28 ml per kg of extra blood, okay, by the delayed cord clamping. So in all preterm or term babies, recommendation is there for delayed cord clamping because of these evidence-based benefits are there. Now, transitional circulation term units. So already we have discussed that preload changes during transition. That depends on lung aeration. Cord clamping before lung aeration, there will be sudden loss of venous return and there will be decrease in cardiac output. Cord clamping after lung aeration. If so, cord clamping we should do after lung aeration or after establishment of the pulmonary ventilation. So first ventilation should happen of lungs. After that only cord clamping should be done. So if we are doing after lung aeration, then there will be increased pulmonary blood flow will replace the loss of the preload causing by cord clamping. If we are doing before lung aeration, then there will be loss of the venous return and reduction in the cardiac output. But after lung aeration, because now pulmonary blood flow has increased, that will supply to the preload. Myocardial contractility also will increase after birth and cardiac output will be increased because of this increase in contractility and increase in compliance. But major contribution is not by this increase in contractility. Major contribution is still by the increase in preload. So after birth, cardiac output is maintained mainly by increase in preload, not by increase in myocardial contractility. So this study was done in extreme preterm babies, ventilatory assistance before umbilical cord clamping. So as we have discussed, the cord clamping should be done after establishment of the pulmonary ventilation. So in this, they have done that just after birth. First, they have ventilated the baby, established the pulmonary ventilation. After that, they have done umbilical cord clamping. But in this study, they did not show that providing assisted ventilation before cord clamping in extremely preterm babies reduces the IVH or early. In this study, they have not found that any reduction in IVH or mortality. But more studies we need on this for safety, feasibility, and efficacy of assisted ventilation before cord clamping. One more study was done, resuscitation with intact cord versus clamping cord in late preterm neonates. So in resuscitation with intact cord or clamping cord immediately. In this, they have found that in term and late preterm babies, resuscitation with intact cord results in better postnatal physiological transition than the standard practice of resuscitation after immediate cord clamping. So if we do resuscitation with intact cord, that will be better postnatal physiological transition will be better in this study. But still, this is not a standard practice. Some studies are going on this. So in preterm babies, transitional circulation preterm. Preterm babies, what is happening that lungs are still immature, alveoli is still collapsed because surfactant deficiency is there, alveoli are collapsed. So lungs are not expanded completely. Still, so lungs aeration are very less. Because of that, PVR also is high. So in preterm babies, lungs are collapsed. Because of that, pulmonary vasculature also will be collapsed. So PVR will be high. So there will be less decline in the PVR in preterm babies. So after birth, there should be decline in the PVR, but because of the lungs are collapsed in preterm babies, so there will be less decline in the PVR. So PVR will be higher in the preterm babies. And pulmonary vasculature also is underdeveloped. Because of that, also decline in the PVR is less. So because of the both above factors, increase afterload for RV and decrease preload for LV, leading to decreased cardiac output. So in preterm babies, risk of the hemodynamic instability or shock will be higher, because here still PVR is very high. And because in high PVR, there will be increased afterload on the RV. Right ventricle afterload will be higher because of the higher PVR. And there will be decreased preload to the LV, because now PVR is high, so pulmonary blood flow also will be less, and that pulmonary venous return to the left atrium also will be less, means preload also will be less. Because of the less preload to the left ventricle and higher afterload to right ventricle, there will be risk of the decreased cardiac output and shock to the preterm babies. So that's why these babies, preterm babies, will have shock for around up to 24 hours. They have higher risk of the shock. And one more thing, PDA will be there, that will also cause left to right shunt, that also will cause hemodynamic instability. Okay, so if persistence of fetal shunts happen, then what happens? So sometimes in preterm babies, the duct will not close, especially in less than 28 weaker babies. That will cause left to right shunt and systemic hypoperfusion. That also can cause system shock in preterm babies. So disorders of transition. So if these changes does not happen smoothly, then baby can develop some disorders that we call disorders of transition at birth. Failure to drop in PVR or increase PVR at birth. Sometimes if there is no decrease in PVR because of any reason, because of these reasons, then baby will develop PPHN, that will call persistent pulmonary hypertension of newborn. Persistent pulmonary, because pulmonary hypertension was there, that should have decreased, but it is persistent. So we'll call persistent pulmonary hypertension of newborn. That can happen in RDS babies, because still babies' lungs are collapsed, pulmonary vasculature is immature, vasculature also is collapsed, so there is no decrease in PVR, so PPHN. MAS babies also can develop PPHN, pneumonia, sepsis, hypoxia also can cause PPHN, acidosis. These are hypoxia and acidosis causes pulmonary vasoconstriction. Because of that, there will be increase in PVR and PPHN. Pneumothorax, TTNB, if there is uh, lung fluid does not clear at birth, there is the remaining lung fluid is there in the lungs, that will cause transient tachypnea of newborn, CDH, and other congenital abnormal. So these are the disorders of the transition if there is failure of decrease in the PVR. So we have discussed all the transition problems of the baby and what are the fetal circulation, what are the changes that happen at birth. Thank you so much.